First part of this is going to be inspection, so I'm going to be looking at my patient's back here, looking for any visible edema and seeing if there's any moles, scars, lesions, or rashes that could affect my instrumentation. So I'm going to use a nerve scope. I'm going to start in the cervical spine, so I'm going to pinch these as close as I can to form a tight seal against the skin without, with it being as wide as it can. I'm going to turn it on, make sure it's to medium sensitivity, and then I'm going to run it up cervical spine. And then looking for any breaks. A break would be a shift to the left or to the right, and if I find one, I'm going to go ahead and run it over that spot 3 times to double check. And then for the thoracics, widen them up a little bit. Okay. Go down. And same thing here. If I find a break, I'll go over that same spot 3 times to double check. And then if I find a break over here on the left, I would mark it on the trailing edge on the same side on this top part. And then for the cervicals, if you pretend that this is pinched, I would be marking it underneath the nerve scope. Okay. And I'm going to be palpating for any edema or pain on palpation. So I would kind of do the same thing, running my fingers across the spine, along the sides of the spine, checking for any edema, which is like a spot of bogginess around the spine, and then pain on palpation, especially in the areas that we marked. Okay, so then I'm going to come down to the SI joint, checking for any pain on palpation here. At the top of the joint, middle of the joint, or bottom of the joint. Okay, so I'm going to start with the occiput, come to the mastoid, and come off to the C1 TVP. And I'm going to put my finger right in between, and then I'm going to laterally flex the head to the side. If it closes down on my finger, it's a good thing. If it doesn't close down on my finger, that's the side of laterality. And so the same side, if this left side didn't close down on my finger, I would isolate this side now and check anterior to posterior, posterior to anterior. So anterior to posterior, grab the patient's head and I'd rock it backwards in that corner, in that direction. And then for posterior to anterior, I would come forward and rock it forward in that same direction. For the mastoid and C1. And so I'd have the patient rotate their head. So if this side does not roll forward, that means that the occiput is posterior on this affected side and this involved side. If you find something on this side, you have to make sure that you relate it back to the other side. Okay, so for the atlas, I'm going to come down to C1, oops, and C2. And then I'm going to have the patient laterally flex to this side. If it doesn't close down, that's also the side of laterality. I'm going to come back to the arches. And then I'm going to rotate their head, push through, rotate, push through. And then whichever side is restricted in that rotation is the side of restriction. Again, making sure you correlate it to the side that had the open wedge. I'm going to have my patient close his eyes. And then you're going to move your head up and down like you're nodding until you come to a comfortable position. And then if his chin was lower than horizontal, it would be an AI, and his chin was above horizontal, it would be an AS. And then next, I'm going to motion palp the thoracic spine. So say if I found a break here, I would make sure that the break is in my middle finger and I go right around it. Okay, and so I'm going to have the patient flex forward for me. And my fingers should spread apart on this. If they don't, then you have the posteriority. Then I'm going to have you flex this side for me and go to the other side. You should feel a curve in the spine. If it's flat or remains stacked, that's the side of the open wedge. And then I'm going to have you rotate towards me. On rotation, rotate this way. My fingers should flare open. If they don't flare open, that's the side that's stuck. This first pelvis, I'm going to come to PSIS. I'm going to have you bend forward. The side that actually shifts forward is the side of laterality. Come back, sorry. Side of laterality. If one stays back and then the other one catches up to it later, it's a wobble, which can be indicative of something in the sacrum. SI joint, SI joint, and then I will bend them on the same side. And if the joint has no motion or it's painful, this is the involved side. I'm gonna check glute height. So I take the slack of my patient's clothing, come to the gluteal fold, and then a higher glute would be indicative of an AS, and a lower glute fold would be indicative of PI. Next, for the leg lift test, I have my hand on the PSIS and the S2 tubercle. So I'm gonna have you lift this same side leg. A good finding would be my thumb on this side going down. If it doesn't, it's indicative of an AS ileum. And then I'm gonna have you lift this same leg, the opposite leg. And then a good finding would be this hand to move down. If it doesn't move down, it would indicate a PI ileum. So for glute width, a wider glute would be indicative of an IN, pelvis IN, and then a narrow glute would be indicative of EX, pelvis EX. We're going to take the patient's knee, rotate it inwards. If the SI joint does not move apart, it's an IN. And then I'm going to take the patient's knee and rotate it outwards. If the patient's knee, SI does not close, it's an EX.